This is a very exciting field. We have so many possible new markers. I didn't disclose most of them actually during the talk, but we talked about NFL in detail. I think you will see from looking at this panel of markers how extensive the process of bringing a biomarker from research setting to the clinical setting is. Like for example, for neurofilament light chain, where we have, I would say, most of the data in the field of multiple sclerosis regarding a soluble body fluid marker, we are very close to getting into the clinic, because what we have been looking so far is an FDA approved assay and instrument to run those tests on. But we know a lot about how we should use NFL, what is the meaning of an NFL value in an MS patient, with our work also in the context of remyelination. For the other biomarkers, they are at different stages. For some of them, there are very well working assays, but they need further validation to define their clinical context of use. For some of the other markers, we are really very early at the stage of discovery and assay development. So I would say we have biomarkers at almost all different stages. Some of them are very close to the clinical setting, while others still definitely need more work. Same applies as well for the MRI. I mean, it's probably easier that we are using clinically available MRI scans, so that part doesn't need extra validation. But what we need to validate is really what those sequences are showing when we look in tissue level. Are they really reflecting what we are expecting them to reflect, and are they delivering the outcome we want them to deliver? And if this is not the case, there might be a need to develop even more specific sequences, and I know this is a topic many groups are working on very actively, and there is a lot of excitement about it as well. The beauty of the wide panel of biomarkers we have now is that we are not only looking at the ultimate change in the tissue, for example with neurofilament light chain where you see tissue injury, but we are actually looking at a lot of mechanistic approaches and a lot of proteins that would reflect every individual state and story. For example, with the data we showed on the REBEL trial that was conducted by Eric Green, we saw that there are patients who responded to clemastine in a different way. Some of them improved a lot and some improved modestly. And those patients were actually clinically quite similar. So they were having similar age, they were all stable. So just looking at the broader clinical picture, you wouldn't necessarily find a reason why the patients will respond differently to the drug. But if you look at their serum proteome, the group that responded very well to the treatment had actually different signature in their blood than the group that didn't respond optimally. And I think that's really where we want to go with our biomarkers in the future, to dissect the disease population and give every population the treatment that works best for it. It's a long pathway, but I think the fact that we are finally having tools that make that possible makes this a very, I would say, exciting decade for biomarker research. I would definitely recommend, as I mentioned in the talk, not to rely solely on one biomarker as an outcome parameter for a clinical trial in remyelination. Let's leverage the different tools we have now. Let's find out whether our remyelinating drug really induces functional electrophysiological recovery. Let's find out, is it really protecting our axons? Let's find out where in the brain we can see the changes happening, and we can study also every patient's signature related to the remyelination happening. I think by leveraging all those tools together, we are really very close in getting one of those remyelinating drugs to the clinical setting.